We are starting in 3, 2, 1. Ma'am, please start. We are now online.
Namaste and good evening, everyone. A very warm welcome to today's webinar on Oncology Talk 2026. We are delighted to have all of you with us this one-day live webinar, where leading experts will share their valuable insights on the evolving landscape of oncology. Now it's my honor to invite our program convener, Dr. Roshi Shah. He is consultant medical oncology, Apollo Center, Cancer Center, Ahmedabad. It's over to you, sir.
Thank you so much, Anjali. Good evening, all. So it gives me great pleasure to invite you all in this forum, Oncology Talks 2026, where we are going to discuss a few topics like metastatic lung and metastatic breast. So straight away, we will start with the lung cancer part. And we are going to discuss immunotherapy, a new era in the non-small cell lung cancer advanced cases. So I will invite our first speaker, Dr. Jay Dadania. He's my dear colleague and he's a consultant medical oncologist at HOC, Ahmedabad. Over to you, Dr. Jay. Yeah, your slides are visible, Jay. I think you need to unmute yourself if you have not done. I think Dr. Jay has disconnected.
Sir, he is having some internet issue. He is joining in just 1 minute.
Okay, right.
Yeah.
Yes, welcome back, Jay. Can you continue?
Hello. Hello.
Yes.
Yes, am I audible?
Yes, you are audible.
Yeah. Sorry for the delay because my connection was unstable. So very good evening and thank you, Rushit, for inviting me for this oncology update. Today, I will talk about the role of immunotherapy in the lung cancer, and we will talk for the metastatic lung cancer. Also, we will talk the role of immunotherapy in stage 3 lung cancer, and we will talk about the neoadjuvant setting. So let us see one by one. So next slide, please. So as we all know, the mechanism of action of immunotherapy. So immunotherapy, they are acting on a variety of immune checkpoints like PDL1 or PD1 or CTLA4, and thereby they causing the inhibiting the inactivation of the immune cells by the tumor cells, and thereby causing the activation of the immune cell, and that can kill the tumor cells. Next slide, please. So how the human immune system based therapy that have more advantage over targeted therapy and the conventional chemotherapy is that they are more adaptable based on the tumor genetic and epigenetic changes. The immune cells have memory function, and that is why the immunotherapy have durable responses even after discontinuation of the drugs. We can see because many of the patients who achieve complete response even in the metastatic setting, they can have a more durable response for a longer duration of time. So they have more durable responses, and they have potential anti-tumor effect irrespective of the tumor type. So if PDL1 is positive or those with microsatellite unstable, irrespective of their the type of tumor they are working in this setting. So majority of the tumor types they are responding to immunotherapy, including the melanoma, the first disease where immunotherapy has been tested. Then comes the non-small cell lung cancer. We have immunotherapy for the head and neck cancer, RCC, HCC, as well as Hodgkin lymphoma and the breast cancers. So these are the major use of immunotherapy in today's era. Next slide, please. So we will see one by one. First, the use of immunotherapy in non-small cell lung cancer in the second line setting. So first, they have been tried in the second line setting, and the first agent being the nivolumab versus conventional chemotherapy, which is the docetaxel, checkmate 017 and 057 trial, and that showing clear advantage over docetaxel in terms of PFS. And important thing is in second line setting, the nivolumab it is much more tolerable as compared to docetaxel. So nivolumab has been approved based on this trial as a second line setting in metastatic NSCLC. Next slide, please. And there comes next slide, please. The keynote 010 trial where pembrolizumab has been tested in the second line setting, which also showing improvement in the PFS as compared to the docetaxel. And then comes the third immunotherapeutic agent, which is atezolizumab, that has been tested in Poplar and OAK trial, where as compared to docetaxel, there is a significant improvement in the median overall survival as compared to docetaxel. The hazard ratio being 0.73, so 27% reduction in mortality as compared to docetaxel, and it is working in both non-squamous as well as squamous setting. There comes next slide, please. Next slide, please. Next slide, please. There comes the role of immunotherapy in the first line setting in metastatic NSCLC. So in first line, now we have immunotherapy alone in those patients with the PDL1 TPS score more than 50. We have combination of chemotherapy with immunotherapy in those with PDL1 negative as well as PDL1 positive patients. Then we have double agent immunotherapy in the first line setting in metastatic NSCLC. And then we have a combination of chemotherapy with dual agent immunotherapy. So we will check one by one. So first being the pembrolizumab that has been tested in keynote 024 trial in the first line setting. And there is a clear advantage of median PFS, and there's a clear advantage of PFS as well as OS in the first line setting of using the pembrolizumab as compared to chemotherapy in those with PDL1 more than 50. But when you look at the KP score, the KP curve, the separation of the curve that happened after 3 to 4 months. There is a major therapy, then it takes time to act, and that is why the curve starts separating after some duration of time. So next slide, please. The overall response is also higher as compared to chemotherapy in those with PDL1 more than 50. But when you check the duration of response, so median duration of response is very high. So it is not reached as compared to only 6.3 months with chemotherapy in those with higher PDL1 population. Next slide, please. Then comes the Keynote 042 trial, where the Keytruda that has been tested as compared to chemotherapy in the metastatic NSCLC first line setting. Next slide, please. So the median OS in those with PDL1 more than 5% in check single agent nivolumab trial, the OS is not been changed as so nivolumab has not been approved as single agent therapy in the first line setting in metastatic NSCLC. Next slide, please. TMB we all know is an important biomarker. So those with high TMB level, the nivolumab can work. Next slide, please. So based on this study, single agent pembrolizumab has been approved because it improved the overall survival as compared to chemotherapy in advanced NSCLC patients. So those patients with PDL1 more than 50%, it is approved as a single agent. And in those frail patients with PDL1 more than 1%, Keytruda is non-inferior to chemotherapy. But nivolumab doesn't improve the overall survival, and that is why it is not approved as a single agent or as a monotherapy in first line setting. Next slide, please. Now comes the combination therapy of immuno with chemotherapy in first line setting. So this is the Keynote 021 trial comparing the combination of carbopem with pembrolizumab versus carbopem alone. Next slide, please. And this showing clear-cut advantage in terms of overall survival. The hazard ratio is 0.59. So almost 40% reduction in the risk of death with the combination of Keytruda with chemotherapy as compared to chemo alone, and which is also statistically significant. Next slide, please. And the overall response rate with the combination of IO with chemotherapy, it is almost double as compared to chemo alone. Next slide. This is the Keynote 189 trial. It is a phase 3 randomized trial of Keytruda with chemotherapy as compared to chemotherapy alone. Next slide, please. Followed by maintenance chemo plus Keytruda in the maintenance setting. So this is the Kaplan-Meier curve of PFS and OS. The major important point is that when you combine the immunotherapy with chemotherapy, the curves they start separating early. So with combination of therapy, it would be early as compared to immunotherapy alone, and that is important in those patients with heavy burden of the disease. So the hazard ratio is almost 0.5. So it reduces the risk of death almost 50% when we use along with chemotherapy. Next slide, please. So the benefit of immunotherapy, it is seen in across all the subgroups. But when you see those with PDL1 TPS less than 1%, the benefit is numerically there, but it crossing the line of unity, and that is why it is statistically not significant, but still numerically it is higher. Next slide, please. And the response rate is almost 3 times higher as compared to chemotherapy alone. So the delta is almost 30%. Next slide, please. Now comes the role of atezolizumab plus chemo and bevacizumab. So ABCP regimen that has been tested in IMpower 150 study. It is a 3-arm study that using ABCP versus atezo with chemo alone versus bevacizumab with chemo alone. So next slide, please. So ABCP regimen that has been far superior as compared to bevacizumab and chemotherapy in terms of PFS as well as OS. With the hazard ratio is almost zero point 0.7, so almost 30% reduction in the risk of death and progression. Next slide, please. So based on these two trial in advanced non-squamous NSCLC, PEM carbo and pembrolizumab, it has been superior to chemotherapy alone, and that is why it has been approved as a first-line therapy irrespective of their PDL1 status. ABCP regimen is also has been approved as a first-line chemoimmunotherapy regimen irrespective of their PDL1 status. And this ABCP regimen can also be benefited when you see the subgroup analysis of iron power 150. It has been beneficial even in the second line setting, those who have progressed on EGFR or ALK inhibitors. Next slide, please. Now comes the role of dual agent IO therapy. So first trial is the MYSTIC trial where the durvalumab and tremelimumab dual IO it has been tested in the first line metastatic NSCLC. Next slide, please. But this trial doesn't show any significant improvement in terms of OS and PFS. So it is a negative trial, MYSTIC trial is. Now comes the second dual agent IO, which is ipilimumab and nivolumab. So Opdita plus ipilimumab. Next slide, please. In Checkmate 227 trial, that is significantly showing improvement. Next slide, please. PFS as well as OS. So this is the median PFS data. So it is the hazard ratio of PFS is almost 0.58. So it reduces the risk of almost 40% in progression as well as death. Next slide, please. Next slide, please. Also, it improving the median overall survival. And when you see the duration of response, the dual IO, the duration of response is almost very high. It is not reached as compared to 5.4 months with chemotherapy alone. Next slide, please. So based on this trial, Checkmate 227, Nivo plus ipilimumab that has been approved. It has superior PFS as compared to chemotherapy. So it has been approved as a first-line double IO agent in metastatic NSCLC patients. But the MYSTIC trial is negative. So Durva and tremelimumab that has been not been approved as a first-line setting. So next slide, please. Now comes the role of dual IO with 2 cycle of chemotherapy based on Checkmate 9 LA data. So based on that, there is significant improvement in terms of overall response rate. It is very much higher, and the PFS as well as OS. So combination of dual agent IO with chemotherapy, that is far better as compared to chemo alone. Next slide, please. So based on that, it has been approved dual agent IO with chemotherapy in the first line setting in metastatic NSCLC. Now we will see the role of immunotherapy in stage 3 NSCLC. So there comes the trial Pacific, where the durvalumab has been tested in those who are not progression post CTRT stage 3 NSCLC patients. In these patients, that has been treated with durvalumab versus placebo for a year. Next slide, please. And this is the 5-year data of Durva versus placebo. So the hazard ratio of disease progression is almost 0.52. So 50% reduction in the progression-free survival as compared to without any treatment. So next slide, please. So based on this trial, durvalumab that has been approved as a maintenance therapy or as a consolidation therapy post CTRT in those patients who are not progression. And the toxicity is quietly manageable. So next slide, please. So durvalumab already approved for stage 3 NSCLC post chemoradiation. Next slide, please. Now we will check the role of immunotherapy in neoadjuvant setting in NSCLC. So neoadjuvant is an important setting because these patients can quite be curable. And as of now, till few years back, we don't have anything specific for the neoadjuvant therapy apart from chemotherapy. And with chemotherapy also, we don't have much improvement in the survival in the neoadjuvant setting in the early stage NSCLC patients. So we will check what is the benefit of adding immunotherapy in chemotherapy. So next slide, please. So
Sorry
there
to
are 3
interrupt in
trials.
between, sir. Sir, in
Yes, these
sort of
are
time, I request you to please conclude in 2
last 3
minutes.
slides. So yes, these are only last 3 slides. So in Checkmate 816 trial, this is the first trial of using nivolumab with chemotherapy, 3 cycles followed by surgery. So this showing there is significant improvement in event-free survival. So the delta is almost 10% even after 5 years. So 5 years data showing there is significant improvement in the event-free survival with nivolumab and chemotherapy 3 cycles as compared to chemo alone. Next slide, please. Second trial is for Keytruda. It is a Keynote 671 trial that also it is 4 cycle of chemo with Keytruda in NSCT setting followed by Keytruda maintenance. That is also showing significant improvement in terms of event-free survival. So hazard ratio is 0.67, so 30% reduction in the risk of progression as well as death. Next slide, please. And this is the Asian trial where the durvalumab with chemotherapy 4 cycles in the NSCT setting showing improvement in the event-free survival. And when you look at the pathological complete response, 18% of the patients showing pathological CR with IO and chemotherapy in the NSCT setting. Next slide, please. And this is the last role of, next slide, please. This is the clinical trial which is ongoing for the neoadjuvant immune radiotherapy. So immunotherapy along with radiotherapy using dual agent IO, durvalumab and tremelimumab in stage 3 resectable NSCLC shading. So this is the ongoing trial. So let us check the final data later on. So with this, I would conclude my topic. And thank you so much for organizing team.
Thank you so much, Dr. Jay, for covering this vast topic in a very short time. So now moving on to the next session, I will invite Dr. Abhishek Kakru, sir. So Dr. Abhishek Bhai is a senior consultant medical oncologist at HOC Vedanta, and he will be talking on optimizing the first line strategy in advanced EGFR mutated NSCLC. Over to you, Dr. Abhishek
So I'll
Bhai.
share my slides. I'll try and share the slides. Somebody, you have to stop sharing. Okay, so let me share the slides. Can you see the slides?
Not yet. Yeah.
Okay, from the beginning. Now it's okay. You can hear me. You can see the slides, no?
Yeah, now we can see. Yes.
All right. So thank you, Rushit, for the opportunity and Astra for the slides. So basically, the topic is EGFR mutated NSCLC, obviously advanced NSCLC mutation driven, which is EGFR, and how do you optimize? So again, this is a very, very vast topic because when 20 years back, EGFR was, I think, the first mutation and you had Jeftinib, but now EGFR itself is a disease. So if we had to go through this topic, you would have to speak on EGFR 19, you would have to speak on 18, 20, 21. They are all different subsets, need to be treatment differently, and you'd have to speak on EGFR co-mutations and how do you tackle them. So because they are all different diseases which need to be tackled differently. So our first instinct is that you see an EGFR and you immediately jump to prescribing Tagrisso or Jeftinib, but then I don't think every EGFR can be treated in the same way. But for the sake of this conference and time, we'll restrict to only this particular Flora 2 trial, and that is what we are discussing today. So we all know this. It's a very common thing. We all know that mutations are observed in at least 40% and 20% of the patients. So we restrict ourselves to Asians. Asians have more preponderance of EGFR. So about 40% of patients have EGFR mutation.
Hello. I'm not able to hear Dr. Abhishek Rai.
Sir, allow me a minute. I'll just check with him.
Okay.
Can somebody share the slides now? I think somebody will have to share because I think the light went off here. So everything disappeared.
Yes, sir,
Suddenly.
sharing.
Yeah, just
Yes.
share the slides. Now I'll come through the phone now.
Okay, so wait.
Okay. Everybody can see the slides now and you can hear me.
Yes, sir, it
Yes.
is audible.
Okay. So next slide, please. Next. Next slide. Yes. So we were on the blue graph, which is osimertinib, the FLORA trial. So for the first time, you had a third generation TKI, which gave you a double the PFS, almost 18 to 20 months. So right last we were at FLORA, and then we were trying to improve on the other EGFR mutations and maybe co-mutations. Next slide. Can you go to the yeah? So, how about combining the both? I think you had a good trial from Tata as well, which combined Geftinib with pemetrexed carboplatin, and you had multiple other trials. So there is a list of trials which showed you that combining both obviously would give you a better PFS, and there was data to suggest that there was a OS benefit also. But then, obviously, with a pinch of salt, that there is definitely increase in toxicity. They had their synergistic action, which is what the slide is telling you, that combining chemo obviously would give you the cytotoxic effect, which the TKIs were not giving you. And combining a TKI would increase the thymidine synthesis level, which would enhance the effectiveness of pemetrexed. So they both worked in a synergistic way, just like we now combine an IO with a BEV. There is a synergism between them, and it does help. Next. So as I was telling you, these are all the lists. This is a list of all the trials we had from the first generation, like Jeftinib to Erlotinib, where chemo was combined with the TKI, and it definitely showed you that you can see the overall response rate was better, the PFS was better, and some of the trials where the OS was also better. But how about the third generation TKI? Next slide. So, coming back to the original topic, which is Flora 2, where you can see we combined the standard of care, which was an EGFR mutant. Obviously, the criteria remained same, exon 19 and L858. Brain mets treated were allowed. And basically, you had an option of using only osimertinib. or which was Tagrisso, versus chemo, which is standard chemo, pemetrexed, carboplatin, combined with your Tagrisso, and you maintain that with in the maintenance arm with pemetrexed and Tagrisso, or in the standard other arm you just continued with your osimertinib. Obviously, frequent evaluations were done, and the main criteria was the main primary endpoint was PFS. Secondary endpoints are obviously overall survival, and most importantly is your, as far as I am concerned, is your side effect profile or quality of life, because you can combine n number of drugs. Obviously, you will get a better response, you will get a longer patient living longer, but at what quality of life? Next slide. So again, this will tell you that both the arms were well balanced. If you go through all uh, the data that has been put, both the arms, Tagrisso and then chemo plus Tagrisso arm, they were well balanced as far as the type of mutations, the number of patients, the smoking status, the type of disease that was involved, the number of CNS metastases, everything was balanced. So not that one arm was better than the other. Next. So how about the final results? Those you can see the PFS, the progression-free survival. Obviously, you can see I'll just put the HR, which was 0.62, or the PFS was 25 months compared to 16.7 in your only osimertinib arm. So obviously, osimertinib was going to give you us 17, 18 months. It gave you 7 months more than your traditional 8 months, as they say, 8.8 months more compared to your traditional only TKI arm. Next, and that is PFS according to your independent review committee, and it gave you even better results, that about 9.5 months improvement in the PFS compared to your standard TKI arm. Next slide. So again, you can see the PFS was across all groups, for age, for mutation, for your smoking history, the type of mutation. So all were benefiting from the combination arm. It's not that one person was, there's some people who were doing well, but across people were doing well in the combo arm compared to the single agent TKI arm. Next. Again, you can see patients with or without CNS metastasis. Again, with metastasis and without metastasis, the combination arm was doing better than the standard arm. You can hear me, na?
Yes, so you're audible.
Okay, yeah. The one hazard of using the phone is that people keep calling you from behind. So you can see exon 19 as well as L858. Both you can see that in patients with baseline CNS metastasis, they were doing, the combination arm was doing better, as well as in the mutation type of mutation also you can see patients were doing better. The HR for exon 19 was zero point 0.6 and 0.63 for L858. L858 is considered to be a relatively poor EGFR mutation, but the combination was doing better in both. Again, the patients with CNS metastasis had a PFS of about 25 months, which is quite good, excellent compared to your standard thing. If you had done just a Jeftinib or a chemo, you would have got, let's say, 6 months, 7 months. Next slide. So the second interim evaluation that was done showed you again the same. The median OS was not reached in the osimertinib plus chemo arm compared to your standard arm, which was single agent osimertinib, which had an overall survival of 36.7 months. The data is yet to mature, but the last data which has been put up is you can clearly see that the combination arm, the OS was better compared to your standard arm, which was only TKI. Next slide. See, you can again see the 4-year survival at 49 compared to 41%. So there is an improvement of about 20-23% in the combination arm compared to your only TKI arm. The median OS was 47.5 months compared to 37 months. So almost there was an improvement of 10 months compared to your standard oral TKI. Next slide. Next slide. So it's just highlighting the fact that it is the combination arm is doing better, and the same has been reflected across all subgroups. You can see the combination arm was doing better compared to your standard arm. Next slide. So again, whether the exposure to the drugs was far better in the combination arm compared to your standard arm, which is TKI. Obviously, as the patients were living longer, the progression was being delayed. Your median exposure to the drug was much better in the combination arm rather than single agent arm. Next slide. Acquired resistance mechanism. So basically, the mechanism of resistance. There are several mechanisms of resistance as EGFR. Can you go to the next slide? Yeah. So this is the most important part, I think, in entire thing. So we all agree that the combination is good, but if you see the orange bar is your combo arm and the blue bar is your standard arm, and you can see what is happening. The combination arm, definitely the toxicity profile. You can see any grade as well as what you are most concerned with is greater than grade 3. Grade 3 AEs, osimertinib monotherapy, you can see it's 34% combined to 70% in the combination arm. So there is definitely increase in the number of toxicity, and the grade of toxicity is definitely, you can see that the combination was doing much poorer, and you can see the discontinuation rate. Discontinuation rate leading to discontinuation of the platinum was about 17% in the combination arm compared to none in the oral TK arm. So that is the only concern with this thing. If you are able to manage the toxicity profile of the patient, and patient is healthy, fit, or maybe a patient has those kind of bad mutations. So there is two ways of thinking over it. You might do a pure osimertinib in a EGFR mutant exon 19 with no co-mutations, and in an L858 or a 19 with number of mutations, you might choose to use a combination of chemo plus TKI, because you know that the patient is going to do poorly. And if your patient is fit enough, you could do it in every patient, because the combination is better than a single agent TKI, provided you are able to manage the toxicity profile of the patient. Next slide.
Sir, in sort of time, I request you to please wrap up in 2 minutes.
Yeah, it's already done. Next slide. So I'll just conclude. You can go to the. So if you have to compare, see the advantages of using a combo. If you have to just summarize. So you can see the summary slide. So Flora was only TKI. You can see the difference in the PFS from compared to 17, 18 months. It is now 25.5 months in your combination arm. You can see the CNS part of it. Again, it was 15 months in the original Tegrisol trial compared to about 25 months in the combo arm. You can see the L858 arm. So L858 is considered to be a poorer disease with worse prognosis. So compared to your only Tegrisol, which was 15 months, you have now 25 months practically. So as I told you, next slide. If you have to just put on the, so there are several combinations now. We all know this. You can combine it with chemo. You can do a lot of things. It is one of the armamentarium in your treatment of EGFR positive disease in the first line, second line, or beyond. Next. Can you go to the last slide? It's the next is the last slide, I think. Yeah, I think you skipped one. So if you have to summarize, osimertinib, you can see here, osimertinib combination with platinum-based chemotherapy, there was a statistically significant and meaningful improvement in the PFS compared to only monotherapy in EGFR advanced NSCLC. The HR is 0.62. The investigator assessed median PFS was 20.5 compared to 16.7 in your standard arm. Your independent review committee showed you it was even better, about approximately 30 months compared to your standard 18, 19 months, improvement of almost 9.5 months. First line osimertinib plus chemotherapy demonstrated superior overall survival versus osimertinib monotherapy. That also we showed you that at 4 years it was almost 47.5 months compared to your standard arm, which was much less. Additional benefits, as I showed you, in a bad disease like L858, CNS metastasis, all those patients were doing far better in the combination arm compared to your standard arm. So this part of it, the safety profile is as expected, manageable, not extraordinarily bad. But then that is the only concern with the combination arm. And if you are able to manage the side effect profile of this patient, you can use it in every patient, or maybe you can judiciously use it in, as the yellow bar is showing you, in patients who are in a really bad disease and need the combination arm far more than the standard your traditional exon 19, which is considered to be the best form of EGFR disease. With that, I'll conclude. Thank you.
Thank you so much, Abhishek Bhai, for this wonderful insights on the topic. And now moving on to the next session uh, on the Tecentriq subcutaneous. So for this session, I would like to invite our chairperson, Dr. Bhavesh Parekh. So Dr. Bhavesh sir is a senior medical oncologist and head at Marengo Sims Hospital, Ahmedabad. And I'll request Dr. Bhavesh sir to introduce the moderator and the panelist and start the panel discussion.
Good evening to everyone. Thanks, Rusit. And I'm inviting the moderator for this session is Dr. Chintan Shah. Chintan Shah is a dynamic young medical oncologist, and also I think he's going to discuss on the panel discussion, that is Tecentriq subcutaneous, the pioneering innovation in non-small cell lung cancer with subcutaneous immunotherapy. The panelists is Dr. Sahil Gupta, Dipen Bhua, Priyanka Srivastav, Jimmy Dadhania, Ekta Wala, and Akash Patel. Over to Dr. Chintan Shah.
Yes, thank you, Bhavesh sir, for this nice introduction, and thank you, Rushit, and thank you, Rosh. So, without wasting time, I'll start off with the panel discussion. So, I hope my slides are visible now, and they're moving, right?
Yes, yes.
Okay. So, fine. So, as we all know, we are going to talk about this topic, that is advancing immunotherapy in lung cancer, special role of Tecentriq as monotherapy, and the innovation of subcutaneous delivery. So I expect Dr. Sahil is there. Dr. Sahil, Dr. Deepen,
Yes, sir.
Dr. Priyanka Srivastav,
Yeah.
Dr. Jimmy Dadania. Okay. Jimmy is not there. Dr. Ekta is there.
Dr. Ita is going to join in 2 minutes, sir. And
Okay.
Dr. Jimmy has joined already.
Okay, Dr. Jimmy is there. Sorry. Okay. And Dr. Akash Patel. I think all are there. Fine. So we are going to have our next 30 minutes in on these three topics. This is role of Tecentriq as monotherapy, beyond in NSCLC metastatic, and beyond metastatic NSCLC, the role of Tecentriq monotherapy, and what we all know now about Tecentriq subQ formulation. So immunotherapy has transformed the first line metastatic NSCLC scenario since long. So what guides you to the therapy selection? So how do you decide that this is the patient you are going to choose for IO monotherapy or IO chemo combination or just chemotherapy? Dr. Sahil, can you take this?
Sir, depending upon the targetable mutations in NGS
Right.
and the PDL1 score.
Okay. Anything else? Dr. Deepen?
In case of allergy to hypersensitivity reaction to immunotherapy, you can.
Okay. So you mentioned PDL1 score, then hypersensitivity reaction, and what else did you mention?
Targeted therapies in
Okay,
case of
mutation,
any
driver mutation.
targetable mutation
Fine,
is there.
fine. Any other factors anybody would like to add? Dr. Priyanka, would you like to add anything to this?
Oh, yes. First, the most important is that there is no other targetable mutation. That is the first point.
Sorry, I didn't heard. Hello?
Hello.
Yeah. So I didn't got you. I was not able to hear what you said.
So, from patient perspective, patient's performance status, any
Okay.
background medical history. From
Right.
disease perspective, stage of the disease, presence of any impending significant metastatic disease. And from tumor biology side, yes, we need to know that any targetable mutations are present and what is the expression of PDL.
Right. So almost most of the things are covered. So as Dr. Sahil also mentioned, the presence or absence of biomarkers, targetable, actionable mutations, and as Dr. Priyanka added up, the overall tumor burden, how symptomatic the patient is, presence or absence of metastasis, and patient's age and comorbidity. So these are all the parameters which we all put together to decide, that the line of treatment where we want to head towards, and we take a call and explain our patients too. So, whenever you think about the first line treatment options, today there are multiple options with us, especially in metastatic NSCLC without an actionable driver mutation. So we'll be talking about NSCLC, metastatic, both squamous, non-squamous, without an actionable mutation. So you can go with chemotherapy. You can go with chemotherapy with antiogenic agents. We can go with only immunotherapy as monotherapy, IO monotherapy. Can have a combination of IO plus chemo. We can have a combination of IO, chemo, and anti-VEGF. We can have just chemo doublet, and we can have immunotherapy doublet as well. So whenever the disease progresses, the options are limited. So we can choose for chemo alone or chemo plus anti-angiogenic agent or immunotherapy as monotherapy if it was not used in the first line. So we'll discuss about the role of Tecentriq in monotherapy. Yeah. So there was a 67-year-old non-smoker lady who was a professor, newly diagnosed with metastatic NSCLC. Biomarker testing came positive for PDL1, which was high. ADA was negative. ECOG was 1. And we suppose this was no actionable driver mutation, especially no EGFR AL cross 1. So what do you mean by PDL1 high whenever you think about Tecentriq? So it has a slightly different, testing for PDL1 and the definition for that. Dr. Jimmy?
Yes, sir. The PDL1 population, the platform that has been used for Tecentriq is SP142, and the
Yes.
lower tumor cell TC or IC population can be also considered positive and can be used under the Tecentriq,
Right. So the cutoffs
can be
are,
covered under Tecentriq.
yeah. So the cutoff was around 50% for tumor cell
So
and
lower immunopopulation also can be covered in the Tecentriq.
yeah. So they had three different sets. But what you call PDL1 high was TC3 or IC3.
Three.
That is tumor cell.
TC3.
Yeah. So more than equal to 50% of the tumor cells should be PDL1 positive, and at least 10% or more immune infiltrating cells should be PDL1 positive. So either of these three was put as TC3 or IC3, which was also labeled as PDL1 high. So ideal therapy today in today's scenario, what do you choose in your routine practice? IO monotherapy or IO chemo combination? Dr. Ekta? Okay, Dr. Akash Patel?
So it depends on the how symptomatic the patient is and how is the tumor burden. So based on that, I choose chemo plus IO versus IO monotherapy.
Right. So more symptomatic.
The most important is rapidly progressing disease. If I suspect, then I
Right.
add chemotherapy along with immunotherapy.
Yes. So very true. High tumor burden, more symptomatic patient, and as rightly said, rapidly progressing. Then you are tempted to add a chemo in addition to immunotherapy. And when do you choose IO as monotherapy at? And that cutoff is 50%. So everyone above 50%. So somebody with a cutoff of 50% and above, we are more tempted to go for IO monotherapy if there is less tumor burden and patient is less symptomatic.
So yes, in that case, IO monotherapy is preferred.
Right. So this is the data of real world analysis where the IO monotherapy versus chemo IO combination was done in PDL1 first line, PDL1 high patient, non-squamous NSCLC. And you can see there is complete overlapping of the Kaplan-Meier curves. And the median OS was almost similar, 21 months with chemo combination, chemo IO, and 22 months with IO alone. The hazard ratio was also close to 1, meaning there was no difference if you add a combo of chemo to IO or not, but this was in terms of median overall survival. But as rightly said, Dr. Ekta rightly mentioned that these are the three categories where highly symptomatic, more tumor burden and rapidly progressing disease, we have to be watchful and careful because IO alone takes some time to act, well, chemo will have a little faster action compared to IO alone. So although there is no difference in median OS in such patients, but a lot of patients will drop out and may worsen if you're not given chemo, especially the categories which we discussed. So IM Power 110 trial, that was Tecentriq monotherapy for PD-L1 high, first line non-squamous or squamous metastatic NSCLC patient. It was a phase 3 randomized study where this group of patients were who did not have an EGFR ALK mutation were randomized to Tecentriq alone, 1200 milligram every 3 weekly, versus chemotherapy, our standard regimes for non-squamous and squamous, for 4 to 6 cycles, followed by maintenance with the pemetrexed in non-squamous arm versus only supportive treatment for squamous arm till progression of disease. And Tecentriq was continue again till progression of disease or loss of clinical benefit. Primary endpoint was OS in the wild type population, and key secondary endpoints were investigator assessed PFS, overall response rate, and duration of response. So if you see the results, OS in the TC3, IC3, which Dr. Jimmy described, as the PDL1 high. In this population, there is this clear-cut separation of Kaplan-Meier curve starting somewhere around close to 4 to 6 months, and the curves remain separated even for the longer time. The median OS was 20 months versus 13 months. If you see 6 months and 12 months OS, there was significant benefit, 50% of the patient in the chemo arm versus 65% in the Tecentriq arm. So there was 15% more patients surviving at 1 year in the IO arm, especially in the PD-L1 high subgroup. The hazard ratio was 0.59, means there was 41% reduction in the risk of death with Tecentriq compared to chemo alone. Similarly, there was a significant benefit in PFS, similar Kaplan-Meier curves, wide separation, and being they are still separated at the end. A similar hazard ratio 0.59. And here you can see doubling of the 1 year PFS from 19% to 39%. Coming to the overall response rate, again, significantly better with Tecentriq 40% versus 28% with chemo alone. And median duration of response, that was 39 months versus 8 months only. So Tecentriq has one of the highest median duration of response as monotherapy in first line metastatic NSCLC PD-L1 high subgroup compared to the other drugs which are also approved, where roughly it is around 26, 28 months. That is what I remember. I think there is a slide at the end. We'll discuss that as well. So coming to the safety profile, so monotherapy again had a significantly lesser grade 3-4 adverse event, 30% versus 52% with chemotherapy. Again, immune-related adverse events definitely are going to be higher with Atizo compared with chemo, nearly doubled. But grade 3 for grade 3 and 4 immune-related adverse events were 6.6% versus 1.5%. So they were quite manageable. So what is your opinion of PFS, overall response rate, duration of response based on the data of IM Power 110? So Dr. Dipen Bua, is he there?
Yes, sir.
Yes, Dipen, you can take this.
Yes, sir. Based on the report, based on the results of IM Power 110, single agent Tecentriq is the weight those for those have a low disease burden as well as the this one who not very much keen for the chemotherapy. So this is the impressive option who want to avoid the chemotherapy as well as the disease as per the data of IM Power 110. The PFS, ORR, and DOR, all the three are the favorable one.
Right, right. Very true. So I think we have moved on to this since last few years. And based on this trial, is there a preference of one IO over the another, especially in this high PD-L1 patient, the same patient which we are discussing? So is there a preference for using Atizo versus Pembro with anyone? Dr. Priyanka? Is she there, Dr. Priyanka?
Yes. So basically now a real world picture would be that definitely we have a cheaper option in immunotherapy. Otherwise, if we look into the data, Atizo is quite a good option.
Okay. Dr. Jimmy, you have any
So we have
preference
used
about
both
this?
Pembro and Atizo,
Okay.
and we have the more leaning to the Pembro in the monotherapy. as
Okay.
the data came very earlier. But the
Okay.
atezo works well in the liver mets populations as well as in some brain mets patients.
Right. And what about the toxicity? Is there any difference in toxicity have you encountered? So between both the molecules, Dr. Akash?
So with chemo, we always encounter the chemotoxicities.
No, no. IO monotherapy, atezo monotherapy versus pembro monotherapy. So any difference you have experienced, which is less toxic or more toxic out of these two?
So basically, sir, there is no difference between the toxicity profile between the monotherapy if we talk about the atezolizumab or pembrolizumab. But again, I will say that even with atezo only monotherapy, I have never encountered any single side effect till date. But again, with Pembro, yes, there is something like itching and some type of immune-mediated side effects. But in atezo, I have never encountered any
Lesser
side
with
effect.
Adiso. Okay. So that is what the data even says, which we will discuss. And coming to this comparison of Atiso versus Pambro. So Pambro had two different trials where here in 04 to the TPS was more than equal to 1% and here it was more than 50%, just like AMPower 110. So basic differences, as Dr. Jimmy, I think, rightly highlighted, there are more significant number of patients with liver metastasis in the IMPower 110. There is a poorer subgroup of patients. Coming to the median OS, if you see the hazard ratio, you have to compare. The absolute numbers are difficult to compare. So it is 20 months with Atizo, while it was 30 months with the Pembro. But if you see the hazard ratio, it was 0.59, while it was 0.64 over here. So definitely the numerical value of median OS was higher with Pambro, but the hazard ratio was better for Atizo. So 1 year survival rate were also quite identical, 66 versus 52%. Here it was 70 versus 55%. Median duration of response, it was quite high, 39 months with Atizo, while it was 26 months with Pembro in this and 28 months over here. So Pembro was around 26, 28 months, while it was 39 months, significantly better with Atizo. Grade 3 for adverse events were also lesser, 16% with Atizo, while it was 27% with the Pembro in the high PDL1 high subgroup. So I think better median duration of response and lesser grade 3 for adverse events with Atizo. That is what you can say. And a slightly better hazard ratio, but numerically lesser median OS. So again, this is a cross trial comparison, not the best way to compare, but this is what we can look at and get the information from when you compare all this trial. So there is again a network meta-analysis of IO monotherapy versus chemo in this high PD-L1 subgroup in first line with mixed etiology, that is histology, that is both squamous and non-squamous. While if you see the Atizo and this semiplimab has the highest difference versus chemo, that is 10 and a half months and 13 months. While Nivo is 3.5 months, Nivo IP 6.5 months, and close to 7 months with Pambro. So real world data on safety, as we were discussing, the rates of pneumonitis were significantly lower with PD-L1 inhibitors like Tecentriq. It was 1.6% pneumonitis with Tecentriq, while it was 5% with Pembro and 4.5% with Nivo. The p-value was also significant. There was a real world study in older adults more than 65-year age in Japan where rates of pneumonitis were significantly lower in Tecentriq, 5.5% versus 29% with Pembro. So definitely, because of the PDL1 mode of mechanism, there is slightly lower risk of pneumonitis. That is what we can say. And very importantly, the ASMO MCBS, that is magnitude of clinical benefit scale, is giving it a 5 score out of 5. It is a statistically and clinically meaningful benefit. So it has got a very good score of 5 out of 5 for the ESMO MCBA score. And also it has a toxicity adjustment and it has considered OS as the primary outcome data. Coming to the second case, 65-year male, smoking history, 40 pack years, who quit 5 years ago, stage 4B with bone and contralateral lung metastasis, PDL1 60%, comorbidities, moderate COPD, ischemic heart disease on dual antiplatelet, dyspnea on exertion, mild weight loss, fatigue. So what is platinum ineligible? So, and you in routine practice seeing patients who are platinum ineligible, Dr. Sahil?
No, sir. Like we give sometimes low dose carboplatin AUC2. So in my
Right.
practice, if there is a problem with the kidney, so I just don't give cisplatin. I give low dose carboplatin along
Right.
with yeah.
Right, right. So this is, I mean, we have found our own way of using weekly carboplatin, as you rightly said, AUC2 weekly carboplatin. And so per se, most of the times there are very few patients So I can ask what percentage of patients will be platinum or say chemo ineligible in your current practice, Dr. Sahil?
So 10% approximately, 10 to
Okay. So
15%.
everybody agrees with this number, or somebody has 20, 30% patient who are ineligible? Anybody? Or everybody agrees 5, 10 to 15%
Yes, sir.
ballpark figure?
Agree.
Right. So that is what we are seeing. I mean, hardly 5, 10% patient will be ineligible. So these are all the factors we discussed, which are taken into account when we are giving chemotherapy. So this is the question which I already asked everyone. But this is, I think, the data where in real world setting, more than 40% of the patient diagnosed with lung cancer have PS2 and are subsequent have comorbidities are ineligible. So many a times what happens is patient is PS2 because of the disease. And once you start with the weekly chemo drugs, patient's performance status starts improving because the disease starts coming down, and within 3 4 weeks you see that patient has moved from PS2 to PS1. So that is very important to distinguish whether the poor performance status is because of the patient profile or it is because of the disease. And if it is because of the disease, as Dr. Sahil rightly mentioned, we all start on with the weekly dosing of chemo, and that makes the patient better. And many of time, then we can switch over to a 3 weekly regime once the patient's general condition improves. So I think what they are trying to mention here is, I suppose, is the 3 weekly regime where more 40% of the patients are not eligible. What are the unmet needs in this population? We already discussed that limited evidence based on systemic therapy, underrepresentation in trials. The trials don't include these patients, and these patients are having poor prognosis and worse outcomes and poor tolerance to therapies. So what is the preferred strategy in platinum ineligible patients? We all know that is single agent chemotherapy is never, other chemotherapy is never going to work. So it is about the immunotherapy. And anybody would like to highlight in short what was this Ipsos trial, Dr. Ekta? Okay, Dr. Akash.
Yes, sir. Which question?
So Ipsos, what was Ipsos trial all about? Can you highlight in 1 or 2 lines? What was this trial all about?
So exactly, I don't know about this
Okay.
result,
And
sir, for this trial.
okay, no issue. Anyone would like to share their inputs? Okay. Anyone else? Fine. So this was basically phase 3 first line atezo versus single agent chemo in patients who are not eligible for platinum containing regime. And if you see, most of the patients were poor performance status PS2 or 3, or they were good performance but age was above 70 years of age, and they had substantial comorbidities or other contraindications to chemotherapy. Again, EGFR population was excluded. And here they were randomized 2:1 to atezo versus the chemo drug. And the primary endpoint was OS. So this was the representation. Like a lot of patients who were above 70 age, few patients who were above 80 years of age. So almost all the patients, this was the trial for the patients who cannot be included in our routine clinical trials. So who were never there in the routine clinical trials. So this was basically a trial specially done for those patients to show what can be done in these scenarios, because they also deserve treatment. And when chemo is not possible, what to do? And there be a better option with which can give better results with less toxicity? So
Sir,
yeah,
sir,
yes,
can I comment one?
yes, Akash.
Sir, what is the PDL1 status in this trial they have taken?
So PDL1 expression was, all the patients were included. So we'll come to that.
Okay,
So
irrespective of PDL.
yeah, irrespective of PDL1, the patients were included. So patients anyways were not eligible for chemo drugs, or so that you give something and see what happens to them. That was the basic idea. And that's why they were randomized in 2:1 fashion. If you see, it was not 1:1 randomization, it was 2:1 randomization. So atezo versus chemo, the Kaplan-Meier curves, white. If you see the median OS, that was almost similar, hardly small difference of 10 versus 9 months. Hazard ratio was 0.78. This is across all entire population. It was intention to treat population where all PDL1 negative, positive, and high PDL1 are included. If you see the 2 years survival, it was 24% with atezo versus 12% with chemo alone. So it was doubling of 2 year survival with atezo in this population if atezo was given as first line. Overall response rate, there was a delta of 17% with IO versus 8% with chemo alone. And sorry, duration of response was also significantly better, close to 7 months, 7.8 months with chemo, to 14 months, near doubling of median duration of response with atezo. Less grade 3 for adverse events. If you see this treatment at grade 3 for adverse was 16% atezo arm versus 33%. So it was reduced. So median DOR was doubled, 2-year survival was doubled, and the adverse events grade 3 and 4 were half. So this is all about this single agent IO atezo in this high risk subgroup where chemo was not doing that well, or they were not represented in the routine clinical trials. So how about single agent immunotherapy in NSCLC frail patients? So there has been data from other drugs also, the Pepsi-2, the Pembro trial, but it was a small trial of only 24 patients. This was a quite bigger trial. And if you see nivolumab, ipilimumab was also tried in phase 3 study in first line in such patients, but it was recruitment was stopped because of high mortality in this population. Durvalumab again has a phase 2 study where in this patients it was stopped early because of the unexpected high number of fatal events. So this was, I think, Atizo and Pembro are the two drugs. Again, Pembro has very small number of patients with again very limited data. I think Atizo is the drug where it has the maximum data in this category of group where 76% of patients were ECOG PS2. There's almost 75% of patients were more than 70 years of age and 31% were more than 80 years of age. So these are the patients where we are always skeptical whether to treat them or not to treat and how to treat them. So this is one of the good ways to think about. So beyond metastatic NSCLC, so if you see nearly half of the lung cancer cases present in non-metastatic stages, that is stage 1 to 3. And if you see the IM powers 010 role of Tecentriq as monotherapy in adjuvant setting. So this is the DFS curve in stage 2 and 3A with PDL1 TC more than 1%. So it was only 1% here. So any positive PDL1 patient, and there was a clear suppression of PDL1 DFS curves with near doubling from 37 months to 68 months of median DFS. So there was a delta of close to 30 months. What about OS in this population where the PDL1 was positive, that is 1% and above in stage 2 and 3A. So compared to best supportive care using Atizo alone had a significant benefit. 0.77 hazard ratio means 33% reduction in the risk of death. Safety profile was quite comparable. So what is your opinion on the results based on this more than 5-year follow-up data on adjuvant NSCLC with Tecentriq? Anybody has used adjuvant Tecentriq in this scenario? Driver mutation negative, stage 2 or stage 3A. So will you use Tecentriq at any point of time as adjuvant? Dr. Deepen?
Sorry to interrupt in between, sir. Since
Yes.
short of time, I request you to please wrap up in like 2 to 5 minutes.
Okay, fine, sure. So I'll go straight to the other part, that is most important part. That is, again, this was the trial. I will quickly go through this. This was the efficacy and safety of Tecentriq in previously treated NSCLC patient where at least 1 or 2 lines of chemo have been used and at least one line should have a platinum-based therapy. Again, there was a second line treatment comparing Tecentriq versus docetaxel, 1:1 randomization. And if you see this OAK phase 3 data, so there was suppression at around 3 to 4 months, at 1 year, at 118 months. Both the time, the Atizo curves were doing better. 40% patients with Atizo versus 27% of docetaxel patients were alive. This was the OS curve. And if you see, the hazard ratio was 0.73, P confidence within 1, and P also significant P value. Median survival was 9.6 versus 13.8 months. So second line group, again, high PDL1 group, TC3, IC3 were having the maximum benefit of 0.41. TC2 and TC1 were also having benefit, but at a smaller magnitude compared to the high PDL1 subgroup. So at 4 years, a consistently greater survival benefit with Atizo was shown with compared to docetaxel in second line. So at 3 years, 12 versus 21%, and at 4 years, again, still near doubling from 9 to 16%. Was still maintained. Again, there was benefit seen nearly doubling at 4 years from 10 to 18, and here also from 5 to 9% in both squamous as well as non-squamous histologies. Again, as I think Dr. Akash asked this question, so these patients were all subgroup of population TC0, IC0. So this was even 45% of the patients who were PDL1 negative. So this TC1, 2, 3, TC2 and 3, and TC3, that is high, positive, that is more than 1%. And this is TC0, there is an even negative subgroup of patients. They were also benefiting with this use of IO in this subgroup of population versus docetaxel even in second line of treatment. Okay. So definitely this showed that OS benefit is regardless of PD-L1 expression, benefiting extends to patient with stable disease and progressive. It is approved in all comers, irrespective of PD-L1, when you are using it as a second line. So we all know in second line, we don't need PD-L1 status, and it improves OS in patient with PD-L1 negative, irrespective of patients also. And so you don't need PD-L1 testing, especially when you're using in a second line setting. And it is a favorable safety profile compared to Atizo. Grade 3-4 events were 15% with Atizo versus 43% with docetaxel. Tecentriq subQ, the last part of our talk and discussion, that is a subcutaneous formulation of Tecentriq. So have you gone through this? And this was the trial, that is IMSCIN 001, where Atizo subQ was compared with IV, and this were the primary endpoints of concentration trough, area under curve. So these are the two main important points, where concentration trough is the end point where your dosing interval ends, and concentration, the area under curve. So these two are clinically relevant parts, and they have compared and they found that subQ was non-inferior to the IV formulation in both the parameters, C trough as well as the AUC 02, the cycle 1 AUC curve. And across various indications, it was tested: NSCLC, small cell lung cancer, melanoma, urothelial HCC, and they have found similar pharmacokinetic parameters for subQ versus IV drug. Coming to the final analysis of overall survival, again, there was almost similar 10.1, 10.9 months, hazard ratio 0.97. There was no difference in OS also when using subQ compared to IV formulation. And adverse event also had a similar safety profile. So my question is, would you switch to subQ formulation from IV tomorrow if it is, say, available, it is over subQ? You will go on to subQ. Dr. Priyanka, your take on this?
Definitely, it's an ease of administration, reduced time to be getting admitted. And especially
Yes.
if we are using it for monotherapy, subcutaneous can be just not requiring even daycare admission.
Correct. Very, very true. So I think most of the panelists also agree with this, right? Anyone having any difference of opinion? Because it's an easy way to administer. The time taken to administer is very less. You don't need port and all. The patient can be given subQ and they can go home with a very short period of time. So this was a trial done where there was a crossover from subQ to IV and IV to subQ, and then there was patients were given a choice whether they want to go for subQ or IV formulation. And it was found that 70% of the patient preferred Tecentriq as subQ, and over 85% of the patients were satisfied or very satisfied with subcutaneous administration. So 8 out of 10 patients were choosing subcutaneous formulation over IV, and only 22 out of 10 were choosing IV for some reason. HCP reported outcomes almost similar to that. The subQ was perception, HCP, the healthcare professional perception of patient preference, again was in favor of the subQ formulation. Switching between Atizo subQ and IV was well tolerated. At the final analysis, the safety profile of both the formulation were consistent with the prime analysis and were showing similar side effect profile. So we all know we have used Phesgo now since last, I think, more than 2 years. Phesgo is available. I think Roche has developed that mastery of making an IV drug first, and after 5-7 years, the same drug they convert into subQ formulation. So I think this is the second one from there, Roche, and we all have moved to Phesgo since it was launched. Initially, we all had that.
We can move to our next talk because Dr. Chintan sir's, phone's battery has been dead.
What happened?
I got a call from Dr. Chintan sir. His phone's battery have been dead, so we can move to our next talk.
Okay. Any comments from Dr. Bhavesh, sir?
it was really good interaction, or the way Chintan has enriched us for the knowledge that how subcutaneous formulation is important, and especially the Ipsos trial where frail patients or more than 70 years of age, what are the advantage, where most of the trials does not include such type of patients. So and other immuno also tried, but they have not succeed. So I think way forward is the sub-Q Tecentriq or sub-Q Atizo for the frail patient, as well as some have IVSS problem. And this is a really good formulation for the way forward for the cancer patient. Over to Rusit.
Rightly said, sir. Thank you so much. Thank you, Chintan bhai. And now we move on to the next topic. So they are the next two breast cancer sessions. And I would like to invite our next speaker, that is Dr. Mansi Shah. She is a senior medical oncologist at Shelby Hospital, and she will be talking on NHER2 for the treatment of hormone positive, HER2 low or ultra low metastatic breast cancer. Over to you, Dr. Mansi.
Thank you so much, Dr. Rashid. Nice to see you, and thank you for
Yeah.
inviting me to the meeting. Sh do you mind if I share the screen so that I don't have to say next, if I can? I think it'll be easier. Mhm. Okay. So I'll be speaking on HER2 for the treatment of hormone positive, HER2 low, or hormone positive, HER2 ultra low metastatic breast cancer. This presentation is by AstraZeneca. That is just my disclaimer. And I think we are entering a very exciting phase in the treatment of metastatic breast cancer, with a lot of different options, and especially a lot of antibody drug conjugates entering the field. For patients with HER2 low or ultra low, we have a very good antibody drug conjugate, trastuzumab deruxtecan. And today I'll just be presenting the data on Destiny Breast 06 trial, and how to manage side effects of trastuzumab deruxtecan. Sorry, one second. So we know now that HER2 is reported now not only as negative or positive, but we have this whole spectrum of HER2 reporting. HER2 low is now defined as IHC 1 plus or IHC 2 plus with FISH negativity, which is about 60 to 65% of patients with hormone positive disease. And we also have a HER2 ultra low subset, which is IHC 0 with some faint perceptible membrane staining, which is less than 10%. This accounts for 20 to 25% of patients with hormone positive HER2 negative disease. So if we combine both these groups, we are seeing almost 80-85% patients who have some amount of HER2 staining. 10 to 15% patients are truly HER2 negative, which is HER2 null staining. So this is what is depicted in the pictorial. As you can see, absent membrane staining, which is called HER2 null, is seen in about 10 to 15% of patients. So why is this important, and why are we so excited about this? We know that for hormone positive, HER2 negative metastatic breast cancer patients, now the standard of care is first line hormone plus CDK4/6 inhibitor. And patients had the longest run on this. So the median progression-free survival is about 2 to 2.5 years. But after 2.5 years, once patients fail this therapy, all the other agents which are used in second line, third line, increase the median progression-free survival by only a few months, most of them less than 6 months. If we look in the third line setting, we have a median progression-free survival with single agent chemotherapy in the order of about 6 to 7 months. So we kind of extend our life by a total of say 2.5 plus 6 months, 6 months, so around 3.5 to 4 years. And so we definitely are in the need for better treatment agents. So as we all know, trastuzumab deruxtecan is an antibody drug conjugate. It has a highly potent topoisomerase 1 inhibitor payload, 8:1 drug to antibody ratio, and internalization of the ADC and causes cell in the tumor as well as neighboring tumor cells by the bystander anti-tumor effect. The Destiny Breast 06 trial was an open-label randomized multi-center phase 3 trial looking at patients with hormone-positive disease who had HER2 low or ultra-low staining. They were chemotherapy naive in the metastatic breast cancer setting, and they needed to have 2 or more lines of endocrine therapy plus minus targeted therapy for MBC or 1 line of therapy for MBC and were endocrine resistant. They were randomized 1:1 to trastuzumab deruxtecan 5.4 milligrams per kilogram every 3 weeks versus treatment of physician choice. And usually we use capecitabine or a taxane-based chemotherapy agent, which was used in this trial as well. HER2 low were 700 something patients and HER2 ultra low were about 153 patients. And primary progression-free survival in the HER2 low patients was the primary endpoint, with a key secondary endpoint being progression-free survival in the intent to treat population. This included HER2 ultra low plus low and overall survival in HER2 low as well as the intent to treat population. So if you look at the demographics and the key baseline characteristics, median age was around 57, 58. Majority of the patients were whites, but there were about 35% patients who were Asians. So about 35% patients were recruited from Asia. For the HER2 ultra low, there were about 17% patients. And this study required a hormone positive status, which was majority of the patients. Primary endocrine resistance was seen in about 30%. De novo metastatic disease in about 30%. Majority of the patients had visceral disease, so it is about 85% patients. And almost 65% patients had liver metastasis, which we know is a poor prognostic factor in the metastatic breast cancer setting. There were also patients with brain metastasis, about 7 to 9%. And the median number of disease sites was 3. So, as we can see, these are all very poor prognostic factors in the metastatic setting, and these patients were included. Majority of the patients had at least 2 lines of treatment, 67%. And CDK4/6 inhibitor was given in majority of the patients, 88%. First line were 2/3 of the patients, and second line and 1/3 of the patients. So they are all received standard of care treatment for the hormone therapy part. If you look at the PFS by independent central review in the HER2 low setting, which was the primary endpoint, we are seeing a median progression-free survival of 13 months versus 8.1 month, which was statistically significant. And this was also seen in the intent to treat population. So even patients with HER2 low disease showed a benefit. I'm sorry, ultra low. Again, the delta was the same, 5 months. Overall survival in HER2 low as well as intent to treat population was seen. So about 87% in the TDXD arm versus 81% in the treatment of physician choice arm. This was the same in HER2 low and ultra low population. And about 20% patients went on to receive TDXT after they failed the treatment of physician choice arm. And HER2 demonstrated significant benefit in all pre-specified exploratory subgroups. So whether there was IHC 1 plus or 2 plus staining, they received a benefit. Endocrine resistance and primary and secondary, they received benefit. Whether they had liver metastasis, they still had a benefit. And in the HER2 ultra low population, again, we are seeing a PFS and an OS benefit, delta of around 5 months, which was the same in the HER2 low setting, and similar overall survival. If you look at the overall response rate, it is better in the trastuzumab deruxtecan arm, 56% versus 32%. So we're doubling the overall response rate. In the HER2 low population, this is still maintained, 60% versus 26%. So we are seeing a better overall response rate compared to chemotherapy. And we are also seeing a small percentage of patients who go into a complete response. So 2 to 3% complete responses, which of course we never see with chemotherapy. Clinical benefit rate is also higher, 76%, and the median duration of response about 14 months. So this is adding a great quality of life, as well as numerically increasing the PFS benefit and the OS benefit for these patients. If we look at the PFS by time to progression on first-line endocrine therapy with these patients, it doesn't matter. Even if patients have failed endocrine therapy in less than 6 months, so these are considered to be really aggressive biology patients, they are getting the same benefit as hormone-sensitive patients. We are also seeing an improvement in the PFS2 in the overall ITT population and time to progression subgroup. So PFS2 of 20 months versus 14.7 months. And again, this is irrespective of how they've responded to first line of therapy. If we look at PFS by measure of disease burden, patients who have low volume disease tend to have a longer PFS, 15 months versus 8.4 months. And if patients have a high tumor burden, which is more than or equal to 3 local or metastatic sites at baseline, they are still seeing a benefit of around 4 months. So regardless of the disease burden, site of disease, we are seeing a response. So what about safeties? Most common treatment associated adverse event which led to treatment discontinuation was pneumonitis. This was in 5% patients, and peripheral sensory neuropathy in about 1.4% patients. And most common adverse events associated with dose reduction was nausea in about 4.4% patients and hand-foot syndrome in about 16% patients. Treatment was discontinued in about 14% of patients. Dose reductions were seen in 24% and dose interruptions in around 48% patients. So if you look at the most common side effects, most of the side effects are grade 1 or grade 2. More than or equal to grade 3 side effects, we are seeing some amount of fatigue, nausea. We're also seeing neutropenia and anemia. Hand-foot syndrome is usually mild. Adverse events of special interest are two with pneumonitis and cardiac failure. So if we look at pneumonitis, again, any grade pneumonitis in about 11% patients. Majority of them with grade 1, grade 2 pneumonitis. And we are seeing 3 treatment-related deaths. In terms of the ejection fraction, we're not seeing any grade 4, grade 5 events, majority of them with grade 2 events, and no patients with cardiac failure per se. Quality of life is maintained on trastuzumab deruxtecan. So to conclude, the Destiny Breast 06 trial, it met its primary endpoint of PFS and HER2 low MBC, and also overall survival benefit. So we're seeing PFS of 13 months versus 8 months in both the HER2 low and the intent to treat population. Overall response rates of 57% versus 31%. And there were no new safety signals that were identified. Interstitial lung disease remains the major concern. In terms of managing nausea, so now that we know that it is a metagenic agent, the recommendation is to use 3 antiemetic agents and 5-HT3 and 5-HT3 receptor antagonists, NK1 receptor antagonists, and dexamethasone, and day 2, day 3 NK receptor antagonists. With this, majority of the patients have a pretty good control in the nausea. For pneumonitis, symptom identification is most important. So we need to educate patients regarding any symptoms of dry cough, dyspnea, fever, or new worsening respiratory symptoms. If there is grade 1 pneumonitis, we can re-challenge with Enhertu if the pneumonitis is fully resolved to grade 0. However, if it has not resolved within 18 weeks from the last infusion, then we need to discontinue Enhertu. We can give them systemic steroids more than or equal to 0.5 milligrams per kilogram per day of prednisone and until improvement, and then gradually taper over 4 weeks. For grade 2 and grade 3, we are going to permanently discontinue Enhertu and start systemic steroids at a slightly higher dose with gradual taper. And in terms of monitoring, of course, lung examination, pulmonary function tests, oxygen saturation, and a high resolution CT. So one would recommend doing a lung assessment and SpO2 prior to each treatment, of course, which we do. And we can additionally do HRCT every 8 to 12 weeks, along with pulmonary function tests if done at baseline. So to conclude, trastuzumab deruxtecan outperforms chemotherapy in all subsets of patients in hormone positive, HER2 low and ultra low metastatic breast cancer with a median PFS of 13 months and an overall response rate of 56.5%, making this a very important drug in this subset of patients. One, of course, has to be cautious in terms of the side effects of pneumonitis, for which we need to closely monitor with high resolution CT scans done every 8 to 12 weeks. And if there is a grade 2 or grade 3 pneumonitis, we need to permanently discontinue the drug, which happened in about 14% of patients in this trial. Trastuzumab deruxtecan is now included in the ESMO and NCCN guidelines for first-line settings, so chemotherapy-naive patients in MBC after receiving hormonal therapy, so second line. And if they have received prior chemotherapy for the metastatic breast cancer patients, in HER2 low setting, we have 2 ADCs, trastuzumab deruxtecan and sacituzumab govitecan.
Sorry to interrupt you in between, ma'am. In sort of time, I request you to please conclude in 2 to 3 minutes.
Yeah, so I'm done. So, these are the guidelines for the NCCN. Also, it is included in the first line setting as well as second line setting that we're all using. Thank you so much.
Thank you, Dr. Mansi. Just one question. How do you start TDXT I mean, for all patients, do you start with the full dose or just a fixed dose like 200 milligrams something? Or
So, thankfully, as we are including this drug in the first line, like, as soon before chemotherapy, and we are hoping that this drug will be continued for a long time, if the patient has no pneumonitis or cardiac event. I think it's important for the patient to continue the drug. So if I feel there are financial constraints, I usually start at 3.2 milligrams per kilogram, and most of the patients have, which is the lowest dose allowed. And I feel most of the patients do get a very good response, even at this dose.
right, so correct. I have also seen like somewhat reduced dose, like you have mentioned, 3.2 milligram per kg. Patient do respond, and at least without toxicities, most of them.
Yeah, correct.
So thank you.
Thank you.
Now we move on to the next session. And for that, I would like to invite Dr. Manan Waghela, who is a consultant medical oncologist at HCD Hospital, Bhavnagar. And he would be talking on ADCs in the management of HER2 positive advanced breast cancer. So over to you, Dr. Manan.
Okay. Good evening, everyone. Am I audible?
Yes, sir, you are.
Yes.
Okay. Thank you, AstraZeneca, for providing me a wonderful opportunity to discuss about the antibody drug conjugates in HER2 positive metastatic breast cancers. Next slide, please. Yes. First of all, antibody drug conjugate has a three main component. One is the monoclonal antibody, which is linked to the cytotoxic payload via linker. So one is a antibody. There is a drug that is called as a payload, and these two are connected with the help of a linker. This linker can be cleavable or non-cleavable based on that whether the drug is payload is released extracellularly if the linker is cleavable, and if the linker is non-cleavable, then the payload will be released after the antibody drug conjugate gets internalized. So what are the advantage of antibody drug conjugates? This one is the targeted delivery. So drug we can deliver the cytotoxic chemotherapy drug to the particular cell which express that specific receptor. It reduces the systemic toxicity and it enhances the tumor killing. Next slide, please. HER2 directed, currently we are using these two anti-HER2 directed antibody drug conjugate. One is the TDM1 and another is TDXT, that is NHER2. Both are, there is some structural difference in these two ADCs. One is the payload. TDM1 has DM1, that is a tubulin inhibitor, whereas in NHER2, the payload is deruxtecan, which is a topoisomerase 1 inhibitor. If we discuss about the linker, TDM1 have a non-cleavable linker, whereas the TDXT has cleavable linker. If we discuss drug to antibody ratio, it is around 3.5 gem 1 in Garzela and it is 8 gem 1 in NHER2. And about the bystander effect, TDM1 doesn't have or very minimal bystander effect, whereas NHER2 has a significant bystander effect. Main side effects of this TDM1 is the thrombocytopenia, whereas as we know, the main side effects with NR2 is ILD or pneumonitis. Next slide. I will discuss how this antibody drug conjugate will work. When we administer antibody drug conjugate, it will get attached to the receptor which is expressed on the tumor cells. Once the antibody binds to this receptor, either if antibody has a non-cleavable cleavable linker, then it will release the cytotoxic drugs and lead to extracellular drug release that will lead to the destruction of tumor cells. If it has a non-cleavable linker, the antibody drug conjugate will get internalized and it will be lysed by the lysosome. And once the ADC's lysosomes are acted, then there will be intracellular release of these drugs, which leads to the cytotoxic effects. So by this mechanism, And if this payload is highly permeable, then it will pass to the another cell, surrounding cells, and that leads to the also leads to the destructions of surrounding tumor cells. So this is the mechanism by which Enhertu acts on the HER2 low cells also, because in HER2 low cells, that antibody drug conjugate may get internalized by the HER2 positive tumor cells, but the surrounding tissue may not be expressing HER2 positive tumors. But when the antibody drug conjugate get internalized, and this payload is highly permeable, so it will pass to the surrounding cells and lead to the cytotoxicity. Next slide. Now we will discuss the role of the antibody drug conjugate in metastatic CA breast. So this was the trial, that Destiny Breast 3 trial, which proved the role of ADC in second line metastatic CA breast. It included the 524 patients which are unresectable or metastatic HER2 positive breast cancer, and that has been previously treated with trastuzumab and taxane. And the primary endpoint was PFS, and the secondary endpoint was OS benefit. Okay, next slide. If we see the result and efficacy and safety data, that median PFS was 28.8 months with the TDXD, and it was only 6.8 months with the TDM1. And if we see the median OS, it is around 52.6 months with the Enhertu and 42.7 months with TDM1. Next slide. As we can see, the curves are separating very early, and there is a significant PFS advantage of TDXD as compared to the TDM1. And this curves continue to separate for the long duration of time. So there is a clinically significant and meaningful impact of Enhertu on metastatic CA breast in second line. Next slide. If we compare the subgroup analysis, the trial has included both HR positive as well as HR negative cells. The randomization was as compared to the previous pertuzumab received or not. We can see all subset of patients are having a better response with TDM trastuzumab deruxtecan as compared to the TDM1. Whether the patient has received more than 3 lines of chemotherapy, whether they have visceral disease or not, whether the patient has received pertuzumab or not. Okay, next slide. And if we discuss the overall response rate, the Enhertu has an overall response rate of around 80% as compared to the only 35% of overall response rate with TDM1. The only concern with the Enhertu is significant number of side effects that includes ILD and pneumonitis, which is seen in around 17% of patients with Enhertu and 3.4% of patients with TDM1. And this is the trial which established the role of Enhertu in second line setting. Next slide, please. Now we will discuss the after the clinically significant impact of Enhertu in the second line. There is one trial which evaluated the role of Enhertu in the first line setting. So that trial was Destiny Breast 09 trial. This trial compared the response of TDXD along with pertuzumab as compared to the standard THP regimen, and the primary endpoint was investigator assessed PFS as per the RECIST criteria. Next slide. So initially the trial has divided into 3 arms. One arm received only TDXD, another arm received TDXD plus pertuzumab, and third arm received the THP. That was the current standard of care. The risk stratification factor were de novo versus the recurrent disease, HER2 positive or HER2 negative disease, and PIK3 mutation or not mutated. Next slide, please. And if we see the results of the Destiny Breast trial, the PFS was significantly higher with the Enhertu plus trastuzumab arm as compared to the THP arm. It is 14.7 months with the Enhertu plus pertuzumab arm, versus 26.9 months with THPM. And overall response rate is around 85% with the TDSD pertuzumab arm as compared to the 78.6% with the THPM. And more significant is the complete response rate. We have seen around 15% of complete response rate in TDSD plus pertuzumab arm as compared to only 8.5% complete response rate in THPM. And if we see the median duration of response was around 40 months with TDSDM, and THPM has a 26.4 months. And benefits were seen across all subgroups, and there was no any safety arm alarm, and the only concern was the ILD, which is slightly higher in TDSD plus pertuzumab arm. Next slide, please. From this trial, if we consider the significant key results were significant improvement in PFS, that is around 14.7 months versus 26.9 months, and hazard ratios of around 0.56 months. Overall response rate was significantly higher with the TDSD pertuzumab arm, and CR rate was around 15% versus 8%. Next slide. If we see the Kaplan-Meier curve, the curves are separating, and with TDSD pertuzumab has a median PFS of around 14 months as compared to the 26.9 months, and it represents the statistically significant and clinically meaningful PFS benefit with TDSD plus pertuzumab arm, the delta of around 13.8 months. Okay, next slide. Now if we compare the cross trial comparison in the first line HER2 positive metastatic breast cancer, one trial is the Cleopatra, which has from which we received the pertuzumab, trastuzumab, and taxane regimen as the first line. In this trial, the median PFS was around 18.5 months, as compared to in Destiny Breast 9 trial, the median PFS was around 14.7 months. So with hazard ratio of 0.56. So as such, we cannot do cross trial comparison, but this data is quite compelling that Enhertu plus Perjeta has a significant impact on PFS. Okay, next slide. The only significant adverse event that is of major concern is interstitial lung disease. It is seen in around 10 to 15% of the patients, and if we consider grade 3 ILD, it is seen in around 3% of the patient. It leads to the fatality in around 2% of patients. So this ADC related ILD is generally seen in around 5 to 6 months of time, and it can be devastating. So we have to look for the any symptoms, and we need to do screening HRCT on the patients who are on antibody drug conjugates. Next slide. Now there is another trial which has meaningful data on the adjuvant setting in in HER2 positive CA breast. And this is the Destiny Breast 05 trial, which included 1,635 patients with HER2 positive early breast cancer and those who have a residual invasive disease after the neoadjuvant taxane-based chemotherapy and HER2 targeted therapy. That patients were randomized in 1:1 ratio. One arm received the TDXD every 3 weekly for 14 cycles in adjuvant setting, and another arm received TDM1 every 3 weekly for 14 cycles. Next slide. If we see the preliminary data, and the data is quite promising, the invasive disease-free survival rate at 3 years was around 92.4% with the Enhertu arm, and it is around 83.7% with TDM1 arm. So it meets its primary endpoint. And if we see brain metastasis-free interval, 3-year brain metastasis-free interval was around 97.6% versus 95.8%. So the patients treated with Enhertu has a less chance of developing brain metastasis, and the initial overall survival at 3 years was around 97.4% with the Enhertu arm, and it is 95.7% in TDM1 arm. So looking this data is quite promising, and we look further safety of this trial, and it may change our adjuvant treatment guidelines in future for the HER2 positive patients who have residual disease post neoadjuvant chemotherapy. Okay, next slide. And another interesting trial which is evaluating the role of antibody drug conjugate Enhertu in early setting in neoadjuvant chemotherapy. This Destiny Breast 11 trial has included adult patients which are previously untreated high risk HER2 positive breast cancer. The high risk is defined by either T3 or more than or equal to T3 tumors or the node positive tumors. The patients were randomized in 3 arms. One arm received TDXD alone for the 8 cycles in neoadjuvant chemotherapy. This arm were later on stopped recruitment because of poor response. The another 2 arms, one is the TDXD Enhertu along with 4 cycles of Enhertu followed by 4 cycles of TSP, and the third arm was conventional dose dense AC followed by TSP regimen arm. So after the randomization, next slide, the primary endpoint was PCR rate. So we can see that almost 67.3% of the patients received complete pathological response in TDXD followed by TSP arm, and the complete pathological response rate was around 56.3% in the patients who have received dose dense AC followed by TSP regimen, and the delta is 11.2%. And we have to keep in mind that in this trial, almost 50% of the patients are hormone positive and HER2 positive. So this HR positive subset is very difficult to achieve pathological complete remission rate. And even though there are high number of patients who are HR positive, they have received patient has received pathological complete response in almost 67.3% of the patients. So this trial shows the neoadjuvant TDXD TSP demonstrated a statistically significant and clinically meaningful improvement in pathological complete response rate. Next slide. So based on the results of this trial, we can conclude that the evolving treatment regimen in HER2 positive metastatic breast cancer. Currently, the first line option, the standard of care was TSP. It is now being replaced by TDXD plus pertuzumab arm. That is an emerging standard. If in the second line, TDXD has replaced TDM1 based on the Destiny Breast 03 trial results. And for the third line, if the patient has not received TDXD, TDXD is preferred in third line. And if the patient is having brain metastasis, active brain metastasis, we can consider tucatinib based regimen or other ADCs. Okay, next slide. In future, we can have a novel anti-HER2 ADCs that are in development pipeline. We can have a combination strategies that include ADC with immunotherapy, expansion to the early stage disease as we have discussed in Destiny Breast 11 trials, and we may have a biomarker development for ILD risk prediction so that we can predict those patients who can develop ILD early. Okay, next slide. So from my side, key take-home messages are TDXD has Enhertu has transformed HER2 positive metastatic breast cancer treatment paradigm. Enhertu is superior to TDM1 in second line setting. Destiny Breast 9 trial may redefine the first line therapy in HER2 positive CA breast. ILD is a key toxicity to respect, manageable with proactive monitoring, and sequential ADC use with different payloads is also feasible. Okay, that's all from my side. Thank you, everyone.
Thank you, Manan, for covering the entire spectrum of TDXD in the treatment of HER2 positive breast cancer at present. So with this last talk, I would like to thank all the speakers and organizers as well as the sponsor of this program. Anything there, Anjali, or we can conclude the program?
Yes, sir.
We can conclude, sir.
Yeah. Thank you, everyone. Good night.
Okay. Technical team, we can wrap up.
Okay, ma'am.